In this last part of the lecture, we will look into benign neoplastic polyp of gastric adenoma and non-neoplastic polyps such as hyperplastic polyp and fundic gland polyp. We will also look into cancers of the stomach, especially adenocarcinoma of the stomach, and we will briefly look at lymphoma and gastrointestinal stromal tumor of the stomach. Polyps, nodules, or masses that project above the level of the surrounding mucosa are identified in up to 5% of upper GI endoscopies. Polyps may develop as a result of epithelial or stromal cell hyperplasia, such as hyperplastic polyp, inflammation, ectopia, or neoplasia, such as gastric adenoma. Up to 75% of all gastric polyps are inflammatory or hyperplastic polyps. Their incidence is correlated with the regional prevalence of Helicobacter pylori infection. These polyps are most common in individuals between 50 and 60 years of age and usually develop in association with chronic gastritis, which initiates the injury that leads to reactive hyperplasia and polyp growth. The risk of dysplasia in inflammatory polyps ranges from 1% to 20% and increases sharply in pedunculated polyps greater than 1 cm in diameter. The polyps, the hyperplastic polyp, are usually sessile or pedunculated polyp. They are frequently multiple or void in shape with a smooth surface, composed of hyperplastic surface epithelium and cystically dilated and elongated foveolar glands. Fundic gland polyp occurs sporadically and in individuals with germline mutations in APC gene or the DNA repair gene MUTYH. The prevalence of sporadic fundic gland polyps has increased in recent years as a result of increased use of proton pump inhibitors, which inhibit acid production, and that leads to increased gastrin secretion and in turn oxyntic gland growth. It is associated with nausea, vomiting, or epigastric pain, or can be asymptomatic. Fundic gland polyp occurs in the gastric body and fundus. It can be single or multiple, as in this case, and composed of cystically dilated glands lined by flattened parietal and chief cells. Inflammation may be minimal or absent. Dysplasia may occur in FFP-associated fundic gland polyps, and rare cancers have been reported. In contrast, sporadic fundic gland polyps carry no significant risk of neoplasia. Gastric adenoma makes up 10% of all gastric polyps. It usually occurs in patients in 50 to 60 years of age and occurs more frequently in males than females. Most gastric adenomas develop in a background of chronic gastritis with atrophy and intestinal metaplasia, with the exception of those associated with germline mutations in APC or MUTYH. The risk of adenocarcinoma is related to the size of the lesion, whereas the bigger the size, which is more than 2 cm, the higher the risk for adenocarcinoma to develop. It is usually single up to 4 cm, and all GI adenomas exhibit dysplasia, which is classified as low or high grade. Both grades of dysplasia are characterized by nuclear enlargement, elongation, pseudostratification, and hyperchromasia. Gastric adenocarcinoma makes up about 90% of all gastric cancers. The other 10% are made up of lymphoma, carcinoid tumor, and spindle cell tumors. Gastric adenocarcinoma are more common in lower socioeconomic groups and in individuals with multifocal mucosal atrophy and intestinal metaplasia. Gastric dysplasia and adenomas are recognizable precursor lesions associated with gastric adenocarcinoma. The cause of the overall reduction in gastric cancer is most closely linked to decreases in H. pylori prevalence. Factors to develop gastric adenocarcinoma includes H. pylori infection, diet of smoked, salted foods, pickled vegetables, low socioeconomic status, and smoking, chronic gastritis, partial gastrectomy, gastric adenoma, family history of gastric carcinoma, and people with blood group A. Factors that can reduce risk of gastric cancers include intake of green leafy vegetables and citrus fruits, vitamin E intake, vitamin C intake, and beta-carotene intake. Any factors that can lead to hypochlorhydria and achloridria can favor bacterial overgrowth and prolonged chronic inflammation in the stomach. This can lead to increased cell proliferation, and that can lead to increased risk for mutation. It can develop into dysplasia and carcinoma. These factors include H. pylori chronic gastritis, autoimmune gastritis, and partial gastrectomy and menetrier disease. The gene that is associated with diffuse gastric cancer is E. Catherine loss, whereas intestinal type gastric cancers is associated with increased signaling via the WNT pathway. Gastric adenocarcinomas are classified according to the location and gross and histologic morphology. Most distal gastric adenocarcinomas occur in the gastric antrum, whereas the lesser curvature is involved more often than the greater curvature. Grossly, there are two types of gastric cancer that we can see. One that is having a single bulky tumor. This one shows an ulcerating tumor. And another one is infiltrative tumor that grows along the wall of the stomach, like this one. This is Linitis plastica. Okay, so gastric tumor with a bulky form of tumor usually are composed of intestinal type morphology, and the infiltrative growth is usually composed of signet ring morphology. Distinguish between the type of ulcer that we can see. This one is a punch out ulcer that we have seen before in peptic ulcer disease. The margins are not elevated. The ulcer base is clean because of the action of the pepsin and the acid. Whereas here, usually in malignant ulcer, the base is necrotic. It's dirty because usually they are associated with achloridria. Okay, there's a hip up margin because of the proliferation of the malignant cells. In the intestinal type carcinoma, you can see glandular formation or papillary structures, whereas in diffuse type carcinoma, it is usually a single signet ring cell that infiltrates the wall of the stomach. Yeah? So remember, the bulky form of tumor is usually associated with intestinal type carcinoma, whereas the infiltrating Linitis plastica type is associated with the signet ring cells. Gastric adenocarcinoma can locally spread to adjacent organs, omentum, duodenum, lower esophagus, and pancreas. It can also spread by lymphatics. The early regional lymph node is the supraclavicular Virchow's node, such as in the picture. There's also transcoelomic metastasis via the peritoneal cavity to the ovaries. It's called the Krukenberg tumor, and this can cause ascites. There's also blood hematogenous spread into the liver, lung, brain, and bone marrow. Sometimes there is a Sister Mary Joseph nodule, an umbilical nodule, where it is metastasis to the umbilicus. The depth of invasion, the extent of nodal involvement, and distant metastasis are the most powerful prognostic indicator for gastric cancer. The prognosis is quite poor. Lymphoma makes up about 5% of gastric malignancy. The most common are lymphomas of mucosa-associated lymphoid tissue or MALT. MALT lymphomas can show complete regression following successful elimination of H. pylori infection. In this picture, you can see the MALT lymphoma replacing much of the gastric epithelium. Another important tumor that can affect the stomach is the gastrointestinal stromal tumor, which originates from the cells of Cajal, a cells that regulate peristalsis. It features smooth muscle, neural or fibroblast cells, and has c-KIT gene mutation or PDGFRA mutation. It's associated with cytoplasmic tyrosine kinase, and it responds very well to treatment with tyrosine kinase inhibitor. So grossly, you can see the tumor is solitary usually and is well circumscribed, a fleshy mass composed of these bundles of tumor cells, and they are spindle shaped in appearance.